Good afternoon, everyone. We are the Senate Budget and Tax Committee Subcommittee on Health and Human Services. We have a few members that are traveling long distance and making their way here, but we're going to go ahead and get started knowing that they will catch up and regroup with us if they don't make it in time for the hearing. So we are going to have one budget before us this afternoon. It is the Maryland Department of Health Behavioral Health Administration's budget. We have our analyst, Andrew Garrison, here. Good afternoon.
Good afternoon. Good afternoon, everyone. Thank you, Madam Chair, member of the subcommittee. We have the Behavioral Health Administration budget in front of you all today. We have about a $2.6 billion budget in front of us here in the fiscal 2023 allowance. And this actually represents a bit of a decrease that we're seeing, but really that's largely driven by some deficiencies that were provided in fiscal 2022 when the governor's budget came in. We've put that in front of you in the kind of hashed or dotted sections, and once you remove those, 2022 to 2023 is actually relatively flat funded. First, to foreground what we have here, a lot of the dollars associated with this are for provider reimbursements for individuals in the public behavioral health system. And so first, in Exhibit 1, we're showing the number of those individuals who've been served by the public behavioral health system. So these are folks that are on Medicaid but receiving specialty behavioral health services here in the state. And also so we have some Medicaid dollars associated with this. That's actually the largest share of this budget. And we also have services that aren't Medicaid eligible but for those Medicaid enrollees. And so on Exhibit 1, we have the number of individuals served. And as you can see, since fiscal 2019, that number that's been reported by the department has actually been decreasing. And what's interesting is that, of course, this decrease has occurred over a period where we've known that there's been the coronavirus pandemic that has not only perhaps increased the need for services, but also maybe impacted some access issues. But also, we know that Medicaid enrollment has been at least going up during this period because the state has been unable to redetermine any enrollees. Additionally, of course, the Administrative Services Organization transition occurred during this period where we're seeing decline in the number of individuals served. So taken together, this suggests to DLS that it's rather perhaps more challenges accessing the public behavioral health system than a reduction in need for this population. In the managing for results, the data provided with us to the budget with us also shows the share of individuals with mental health needs that are being served by the system. And so they brought back this measure actually after having some time not having it reported. And what we see in the most recent reporting for fiscal 21 is a higher share of adults and children who are receiving services, mental health services, through the public behavioral health system when compared to when it was prior reported. Nearly half the kids who have a serious emotional disturbance or a need for these types of services are being served by the public behavioral health system, and almost 40% of adults. Medicaid enrollment is a little bit under a quarter of total Maryland population. So what this is kind of suggesting is that perhaps those individuals in the Medicaid group have a higher need for these specialty behavioral health services than those who are privately insured. Another performance measure that we look at with the budget is readmission rates. The department has set a goal for having readmission rates for inpatient mental health or residential substance use to be lower than 18 or 20% respectively. And so what we have in front of you in Exhibit 3 is showing the share of those individuals who are readmitting within 30 days. And as you can see in 21, although the number of these inpatient stays has gone down, actually the share, particularly when it comes to substance use, has gone up for substance use while going down with the mental health treatment side, although the number of services in both groups has decreased from fiscal 20 to fiscal 21. Another interesting performance measure that's been reported on in recent years has been actually reported for a while with the budget is the use of telehealth services in rural settings. And this is kind of reported specifically as part of a program and partnership the department has done. But of course, as we see since fiscal 20, the share of individuals in rural settings receiving this outpatient behavioral health services or mental health services through telehealth has really increased. Of course, this aligns with the pandemic and more services being expanded through telehealth. And so we have a recommendation for committee narrative here to include further reporting on the broader access or use of telehealth for behavioral health services, not just within this rural population in the program here, to really see if this is a trend that we're seeing elsewhere in the state. Additionally, the last aspect that we want to talk about from the performance measure side of things is the prevalence of medication-assisted treatment. This is a particularly important tool in treating those with substance use disorder, when we talk about perhaps like methadone or other medication management for opioid disorders. And what we see here is it's consistently around about 30% of individuals who are receiving these services are able to receive or are receiving a medication-assisted treatment. Of course, this is a really important tool when it comes to treating individuals with those substance use disorders. So we also do have a recommendation around committee narrative for reporting on the prevalence and any barriers of access that might exist in having medication-assisted treatment for individuals here in the state. Moving into the budget section of this analysis, we do have, as I mentioned, a sizable number of deficiencies that came in with the budget this year, the largest of which is for actually service year 21 expenses. So at closeout, traditionally we do see some dollars accrued of the prior year dollars to allow to be paying for those services as bills keep coming in over the course of the year. And usually it's a relatively small dollar amount compared to the size of the program. However, when 21 was closed, the department didn't have any appropriation to accrue any dollars to this purpose, and we're starting to see a lot of bills come in that fiscal for service year 21. We ultimately think this is kind of related to the timing of bills with regards to the ASO and when some of those payments have been needing to go out. And so the state is now needing to use fiscal 2022 dollars to pay for those fiscal 21 expenses. And that's about $340 million that we're seeing at the top of Exhibit 6 there. Otherwise, we do have a rate increase of as relates to home and community-based services that was being added by deficiency. This actually reflects double budgeted funds. $65 million of this is double budgeted. It was actually brought in prior in a budget amendment. And then also there's about another $3 million or so, $2.5 million that was brought in as federal funds and should have been brought in as general funds. The governor corrected that in the first supplemental, but DLS does have a recommendation to correct the other double budgeted funds in fiscal 22, and that would be deleting the $65 million. That we're showing here, the remainder of that deficiency amount. There's also a deficiency that came in for the enhanced federal fund matching percentage that's $21.5 million. This is actually for the third quarter of that. Since the budget was introduced in supplemental number, and the first supplemental as well, we knew that now we're now getting a fourth quarter of this enhanced match as well. That's coming in at the same rate. But what's interesting is that in the supplemental, the governor took the general funds out of this budget where they didn't do that in the deficiency. And so we are seeing that here as well as again, that continuing through the end of this, of the fiscal 2022 budget. We do have $13 million in there of general funds as it relates to the Administrative Services Organization. We'll be talking about that later. And then the last item here, the Easterseals Family Clinic has received a deficiency, and those funds actually continue into fiscal 23 as well. On the federal fund side of things, we do, as I mentioned, have funding as it relates to home and community-based services. Those prior action by you all in the budget has set those funds aside coming in. It was a 10% enhanced match as authorized under ARPA and some of the other federal legislation. And that is has been set aside for a rate increase for those providers. And specifically, there is a component of this that revolves around state share. And so we do have some bold language here to ask the department to comment on the need or availability for some of those state funds, given some of the general fund adequacy concerns that we have a little bit later on. And again, we're seeing a lot of this money already in the budget. It's about $65 million that's currently in there for fiscal 2023. And even though we're deleting those double budget funds in 22, we're recommending maintaining those funds in 23 to maintain that spending authority for these new federal dollars. As I previously mentioned, a lot of this funding does relate to provider reimbursements. The largest components of that are specifically with Medicaid eligible services. And so for those two largest sections of the pie there, we do get federal dollars associated with that. Otherwise, the items labeled MASF are largely state funds or funds of general funds or funds available to the state, but for that Medicaid population. Provider rates are in here. That includes not only the mandated rates under the minimum wage bill, but also those home community-based services rate increases. Additionally, on the topic of the ASO, there is $100 million in this budget that represents funds that will be recouped by the state for the overpayment period, and then allow those funds to go back out to pay provider reimbursements. So that's $100 million of new money. Of that, 11%. Makes a relatively small share of the budget, and looking more specifically at that, the non-fee-for-service expenditures here, we see that a lot of it is still going to various grant programs for either substance use or mental health, a lot of federal dollars and federal initiatives in there. The state also does provide grant funds to local behavioral health authorities or core service agencies to provide services that are outside the fee-for-service structure. And really only about $45 million of this budget relates to something that would look like an administrative expense. So either personnel costs or of paying for the ASO contract that you see there. From a change standpoint, when we look at this budget, again, a lot of the change is going to be occurring in those fee-for-service programs, given that does make up a pretty sizable share of the budget. We're identifying about $10 million worth of new dollars coming in. Part of that is, of course, the mandated rate increase, and then another part of that is looking at those new recoupment dollars that are available that might ultimately be going out. We're offsetting that against some of the other decreases from prior federal dollars to look at really about $100 million new money available for provider reimbursements. Of course, also that largest change there is the one-time deficiency for those fiscal 2021 services. The other thing I would like to note from a change standpoint is Chapter 785 of 2021 has been fully funded in this budget at $2.5 million. We also see some increases in the standard grant programs that we have here. There's two major federal block grant programs, one for substance use and one for mental health. Those have actually been receiving increases throughout some of the federal coronavirus responses as well. And so we're starting to see those increases as well. However, that's more than offset by starting to dwindle down of the state opioid response dollars. That SOAR grant has been a pretty significant amount of funding to the state, particularly, for combating the opioid crisis and substance use disorder, and we're reflecting that here. In Exhibit 10, we show where some of the different fund sources have been, and we are showing that those block grant enhancements that have been authorized through the federal legislation are still providing substantial support for some of these programs above, certainly some of the prior years before that kicked in. But really, that SOAR money decreasing does reflect a pretty sizable decrease. We are actually expecting some more federal money to be coming in, either through SOAR or through some of these block grants as well. And so we are asking the department to comment on the availability of those funds in 23 and beyond. Turning now to the forecast and adequacy of the funds that we have here in the budget. This has always been a really difficult budget to forecast for myself and my colleagues at the department and DBM. However, this year's been particularly challenging given some of the question marks that are presented with the data that's available to us and obviously all of the other concerns around how care is being delivered given kind of the crisis at present. And so looking at fiscal 2022, we can really start at almost two separate places, and those gives us two different numbers to start off with. One, the higher number in front of you starts back at 2019 before the ASO transition and really uses that as a base for services and utilization and builds from there, adds in what we know from mandated rate increases and the enrollment increases that we've seen from the actuals, and gets us to that 661 number. Now, if we go over to the other column that produces a lower number, what we've done there is we've taken the current data from the data provided under the current ASO and then annualizing those values and using that as the jumping off point for 22. And then that does produce a lower number. There's obviously some seasonality issues in there as well. But even just from those starting points, we really get two very different places for what this program might ultimately spend. Further complicating it is how much utilization we think may or may not go up. Building in a relatively smaller utilization, maybe with still some people delaying care or having difficulties accessing treatment, or really having some perhaps pent-up demand in the system and folks going and accessing care that they need, due to some of the mental health challenges that they've been facing during the pandemic. If the state needs to put up additional money for home community services, that provides another general fund need here in '22. And then we do also anticipate some savings in this budget. The enhanced federal fund match, as I mentioned, the governor took the general funds for that as well. But that provided that $21.5 million in savings there, so right in between our two estimates. Also, the Institutes for Mental Disease on the mental health side of things waiver addition has allowed the state to move some services that were previously entirely state funded into the Medicaid program, and so we are expecting some savings there as well. Putting all that together, DLS believes that we could either be almost right on the money or pretty close in the grand scheme of things with this budget in terms of general fund adequacy in '22, or we could be facing a pretty significant deficiency here in the upwards of $80 million. This is even further complicated when we look at '23. Again, we still have some of those same questions around utilization, how much we want that to increase, and even where we're starting off our forecast. But really what drives the difference that we see here is how much of those funds for recoupment are ultimately going to be available to then pay providers for current services. As I mentioned right now, that is budgeted at $100 million. That has been communicated to DLS, so that's a fairly rough estimate of what will be recouped in the fiscal year. And so if it really is less than that, that does reflect a greater need of ultimately general funds or other state funds to meet that demand for services. And so what we've done traditionally in this budget and what we're continuing to recommend is budget bill language that would restrict any provider reimbursements in this program to only be used within that program. So allowing the dollars that are within the Medicaid component of this to be paid, to be used to either pay for those Medicaid services or, again, services for that Medicaid population, and sort of vice versa, allowing that to all be moved but still staying within BHA for provider reimbursements. And just as a quick visualization of some of those adequacy concerns that we have, again, in 2022, we are I think more broadly concerned that a lot of the different outcomes and scenarios that we work through all still necessitate some sort of general fund need or some deficiency. However, 2023 is where we certainly have a much broader range of outcomes given, the real uncertainty about how much funding is ultimately going to be available to this budget. The first issue that we present in this analysis is, of course, as it relates to the ASO. And so I guess to provide a quick refresher, back in calendar 2020, the state transitioned from the prior ASO to a new administrative services organization that was unable to provide services right away in processing claims. And so what the department elected to do was provide estimated payments until the ASO was able to get back online. That estimated payments period ended up going through August of calendar 2020. Of course, as we all know now, a decent chunk of that early 2020 period had the coronavirus pandemic and perhaps the worst of it. And so the estimated payments went out based on service year 19 dollar amounts, but obviously services that were being offered looked very different than what happened during service year 19. And so the difference that we're now seeing is what we're calling overpayments, and this is the difference between what claims were ultimately submitted for that period, because although the ASO wasn't necessarily processing claims in real time during those 8 months, the department had issued a statement to providers to still be submitting claims during that period, and they would get processed kind of eventually when everything got up to speed. And so what we have now is the difference between those claims that were submitted over that period and what was actually paid, so really representing the difference between that service year 19 and what has a claim associated with it currently, or what has a claim been processed and paid for currently. And so what we have here in Exhibit 13 is really just showing the distribution of the estimated payment balance, of the overpayment balance rather. And we can see that's really concentrated with a handful of providers. The entire public behavioral health system is about 2,600 providers. And if we look at that 75% of total amounts owed, right now, at the time of this writing, that total amount owed was about $214.5 million. That data is current as of, I want to say, February 2nd. So a little bit outdated, but still as up to date as we could get for the purpose of this publication. And with about 10% of providers, we have about 75% of the dollars associated with them. Moving up one step to that 90% of amounts owed, we're looking at right around 20% of providers and 90% of the dollars that we still have outstanding. And so we have a lot of providers then kind of on that tail of that distribution who owe the department a relatively small dollar amount compared to certainly, some of the other concentration that we see on the other side of the distribution. What we wanted to do when evaluating it, certainly at this period, because the question really is how much of the difference can we associate to the claims to the services that are being provided over that period, because otherwise the downturn in utilization would drive a larger difference in these amounts owed. So in Exhibit 13, we're grouping providers by percent complete, and what that means is how much of their claims over that period were able to pay off their balance, the total amount of estimated payments that were provided to them over that 8-month period. So someone with 0% complete, are sometimes also called no offset providers. Those are folks who during that 8-month period were unable to submit a claim or successfully submit a claim for services provided. Someone who has 100% complete had all of their claims over that 8-month period equal to or greater than what their fiscal 19 services were, what those estimated payments were. And so we have a couple different observations from this exhibit. One is that in terms of number of providers, they are really concentrated on those two tails. They've either, weren't really doing any work during the pandemic, during this 8-month period rather, and so that's where the largest number of providers are. However, it's a relatively small dollar amount that's associated with them. So it's only about $10 million, again, of about $215 million outstanding. And then, of course, on the other side of things, we have a large number of providers who actually didn't seem to see any real downturn based from 2019, with those 100% complete and obviously don't have any dollars associated with them. And where we really see a lot of these dollars concentrated is with providers who had, 70 to 80% percent complete, and so representing probably folks who were open and operating during the pandemic, but did have some maybe decrease in service utilization or challenges when processing claims, but we're still actively working to submit reimbursements for services over that period, and that's really where we see a lot of these dollars associated. Let's see here. So far, the department has mentioned that, or stated that they will be wanting to forgive providers for amounts owed less than $10,000, and that would include actually paying back someone who has already paid them. So that's about $3 to $3.5 million worth of general funds being needed, and that is coming in from that deficiency that I mentioned a little bit earlier that came with the budget for fiscal 2022. And what we're showing in Exhibit 15 is really how that kind of breaks down. The department has mentioned that even if you had less than $10,000 owed, but you didn't submit any claims during that period, they are actually still, if you're one of those no offset groups, they are still going to be pursuing collections against those providers. And actually all no offset providers will have collections pursued against them. And so they're excluded from this forgiveness mechanism. And we're kind of showing how that breaks down again, and we see that distributionally it is relatively similar to kind of the pattern that we saw with the broader system in terms of more of the work being done and the dollars associated are with those in the kind of the middle share of those percent completes. We do have a couple notes when it comes to the provider forgiveness aspect of this. The first is that the remaining $10 million has been reported to be needed to kind of clear the books of those collections pursued against those folks who were those no offset providers, that $10 million that I mentioned in the previous exhibit. For our purposes, we are asking the department to comment on the need for that if they are already kind of being sent to an outside process to be adjudicated elsewhere. DLS has questions around the need for general funds for them in the fiscal 2022 deficiency. Further, the other aspect of this is, this is only now $3 million of the $13 million that was provided in the deficiency total that we could account for. And so we did some quick math to kind of to think about what other ways to, with this additional funding, how could that assist other providers or provider groups? For instance, about increasing forgiveness up to $25,000, still excluding those folks who were no offset providers. Would only cost us, say, about $5 million, so about half of the remaining $10 million that's been provided through the deficiency. And The language itself, when the deficiency came in, was for issues related to the ASO. So DLS has a recommendation to put budget bill language on that deficiency. First, to really specify that it can be used for provider forgiveness, and then increasing provider forgiveness up to $25,000 if the department so chooses, but only doing forgiveness for those folks under that amount, or being reserved for provider reimbursements. Again, DLS has some concerns with adequacy, particularly in fiscal 2022. So if there is an additional, $10 million outstanding from this deficiency appropriation that the governor's already provided to the department, this could really go a long way in assuaging some of those adequacy concerns that we have in the current fiscal year. Additionally, we have a second recommendation on budget bill language restricting funds from the Secretary's budget, pending a submission of a report, particularly on the forgiveness program, and really focusing on how the department elected to spend the $13 million in the deficiency. Moving on to kind of the broader behavioral health trends that we're starting to see, and perhaps pointing to the need for the services that we're discussing. First, in Exhibit 16 here, we're using national data to look at the drug overdose and the share of those that are opioid related in the state. And as you can see that it's been continuously climbing, and with the most recent data really representing some of the highest watermarks that we've seen for drug overdose deaths in the state. And unfortunately, well over 90% of those are historically opioid related. When we look at the data from the Opioid Operational Command Center, and breaking that down really by region, we see that these are concentrated in Baltimore City. And again, that it is fentanyl in particular that is driving a lot of these opioid-related deaths, being involved in about 95% of those in the most recent data that we have. I will also note that both of these data sets really end in summer of 2021 for us. So given the significant lag of the data, we're still not exactly sure what the ongoing trends are, or sort of the long-term tail of the pandemic might have been on substance use. There is also growing concern around mental health nationwide, and the Surgeon General as well as the CDC have done a lot of reporting and research around potential needs and signs pointing towards increased needs on the mental health side of things as well. And so in Exhibit 18, we summarize a report from the CDC on specifically looking at adolescents and ED visits for suspected suicide attempts with that population, and comparing that to a reference period back in 2019. And unfortunately, it seems like really specifically with adolescent girls, so ages 12 to 17, are really driving an increase in ED visits related to this, to suspected suicide attempts. And additionally, using national data again with some the most recent data being 2021, Maryland is seeing an increase in the suicide fatality rate, and that is actually looking like it's starting to move a little bit counter to the nation, although Maryland is traditionally lower than the nation when it comes to suicide fatality rates. And of course, we would like to highlight that anything related to suicide or substance use or drug overdose is all part of a lot of different factors that may be very different for any one individual. However, we're really trying to collect some of this data to point at national trends or state level trends to look at the importance of these services and what that might project a need going on into fiscal 2023 and beyond. The more current data that we've been able to access is the Here to Help line. This is a crisis services line in Baltimore City from Behavioral Health Systems Baltimore. And of course, we see a spike really early on in the pandemic, but that really didn't, it stayed at those elevated levels for these crisis lines. And in particular, the highest value that we've seen actually is as recently as September of 2021. So really still perhaps suggesting an elevated need for these types of services. There was request made by you all last year in the Joint Chairman's report for this as it relates to crisis services. In particular, the two items are the federal 988 hotline is expected to perhaps drive additional traffic to Maryland Crisis Services with the state, all carriers now having 988 numbers direct to a national crisis or to a suicide prevention hotline. This is expected to put an increased need on those crisis services. Additionally, there was a JCR report around the Greater Baltimore Regional Integrated Crisis System, GBRICS, which is being funded through the HSCRC's Catalyst Grant Program. At the time of this writing, and still to date, I believe these reports have yet to be submitted, and so we are asking the department to comment on those. But that does conclude my presentation, and I would be happy to take any questions.
Thank you very much. That was a lot. Okay, you got it in. Are there any questions for the analyst? Okay, seeing none, we're going to turn to our secretary for the Maryland Department of Health, and I imagine you may be bringing, yes, some of your team with you. Good afternoon, Mr. Secretary.
Good afternoon, Madam Chair and members of the committee. For the record, Dennis Schreiner, Secretary of Health, and I'm joined by Deputy Secretary for Behavioral Health, Dr. Aaliyah Jones.
Afternoon, Dr. Jones.
She will comment she will respond to the written responses to our summary. And for questions, we also have our CFO, Emily Brandenburg, our Senior Director who oversees the Medicaid ASO, Linda Riddleman, and our Budget Director for BHA, Marion Katsourelis. So want to thank the analyst for his very thorough report, very in-depth and well put together. And I'll turn it over now to Dr. Jones for her responses.
Thank you, Secretary Schrader. Thank you all for your time this afternoon. The department would like to thank the governor and the Department of Budget and Management and the budget committees for their support in 2020 and in 2021 with the COVID-19 response efforts. We thank the Department of Legislative Services for its insightful budget analysis. In response to the questions and statements provided to the department, the first one being, given the known prevalence of telebehavioral health services in rural parts of Maryland and the presumed importance that these services offer in expanding access to mental health treatment throughout the state, DLS recommends adopting committee narrative that requests BHA include data on the statewide prevalence of telebehavioral health services with future MFR submissions. Respectfully, the Maryland Department of Health does not agree. As the Behavioral Health Administration nor Behavioral Health Medicaid, we don't have access to the entire utilization of telebehavioral health services throughout the state of Maryland, so we can't gather all of the data. However, we certainly can provide information and data about utilization of telehealth in the public behavioral health system. Additionally, the Maryland Healthcare Commission has begun a comprehensive telehealth study based on HB 123 and SB 3 and last year's legislation. This study may have more complete data than the department can provide at this time. We would encourage you to see the MHCC site for additional information. DLS recommends adopting committee narrative requesting a report from BHA on the availability and barriers to access for MAT. This report should also include data on the distribution of MAT providers throughout the state and include outcome-based performance measures for MAT. The department concurs, but we are requesting a due date of December 1, 2022 versus the October date spelled out. DLS recommends deleting double budgeted and mistakenly budgeted federal funds provided through fiscal 2022 deficiency and the federal funds mistakenly carrying through in fiscal 2023 in M00L01.02 and M001L01.3. However, DLS recommends maintaining the fiscal 2023 federal funds in M00Q01.10 to allow for spending authority of the rate increases into fiscal 2023. The department concurs with this recommendation. Please note that supplemental budget number 1 addresses this issue by providing general funds to support HCBS rate increases within the 2 BHA programs. Given DLS's concerns with general fund adequacy discussed later in this analysis, the department should comment on the availability of new state funds to support the enhancement of home and community-based services and the associated rate increases. Our response being that the state funds are generated through the reinvestment of the 10% FMAP. New state dollars will be required to maintain the rate increase and peer recovery support services starting April 1, 2024. Until then, the enhanced federal dollars will be reinvested back into the program and used to support the general fund share. States are only prohibited from using the enhanced funds to supplant any activities that started prior to April 1st, 2021. And we provided the website link to our latest proposed spending plan. Regarding MDH commenting on the availability of additional block grant funding not yet reflected in the 2023 allowance, The Behavioral Health Administration is awaiting notification from SAMHSA on another state opioid response grant award, and we expect the federal government to provide updates soon, after which time we can say how that money will be spent. Given the wide range of general fund adequacy, including potential surpluses, DLS recommends adding budget bill language to restrict the use of provider reimbursements and the behavioral health budget to that purpose, including funds provided via deficiency appropriation. MDH response, the department concurs. The department should comment on planned uses of this funding, given that no offset providers have had collections already pursued against them. The department anticipates using the remaining $10 million deficiency to repay providers owing less than $10,000 for any recoupment they made, account for any unsuccessful collection from no offset providers, and lastly, to account for any future decisions made by the governor around provider forgiveness. With regards to the next statement, as these funds are provided only for the purpose of forgiveness, DLS recommends adding budget language that restricts the $13 million of the general fund's deficiency to only be used for provider forgiveness of overpayments for those owing less than $25,000. MDH response, the department respectfully does not agree with this recommendation. MDH supports the governor's budget, and the department is happy to provide the requested reports. And lastly, the budget committees were interested in the impact that the implementation would have in the state with regards to 988 implementation and requesting about the JCR reports and for the GBRICS JCR. I'll state that the department is actively working on these reports, and we intend to submit them as soon as possible. And that concludes our responses to the questions. Thank you. Are there any questions?
There are. Senator Rosapet.
Here. On the telehealth, I didn't quite understand. We have data for the rural telehealth, both public and private, or only public?
Only public,
Okay.
only public.
So what you're saying is you can only provide the rest of the state for public?
That's
and-
correct.
And the other folks can come up with the private. Got it. Thank you. Thank you, Madam Chair.
Very good, thank you. Any other questions? I do have just a few, I'm not sure who best to answer them. We may hear from other panelists, but I just want to understand where we are with the forgiveness, and I heard and read your response to the analyst or the DLS recommendations. Just trying to get an understanding for the $10 million, 20, or the 10,000 and 25,000 threshold. Are claims still being processed for those that, and my concern is about the federal funding that we would be perhaps missing out on if we didn't process those that, I figure there's got to be some low-hanging fruit in that bunch that could be processed so that we would not lose out on the federal share of those funds, and maybe be able to help other providers in a larger audience if we take federal funds from that pot to help with that group. Can you, I don't know if I'm making sense, but.
No,
yeah.
absolutely, Madam Chair. I've asked Linda Riddleman to come up. She can help.
There is some remaining tail funds, Chair. We've recouped all but $213.4 million. There's still some denials that require provider action to reconcile and get reprocessed. I don't know that of that amount, some $80 million, and I'll let Chad Burkholder from Optum speak to that, how much of that would eventually be reprocessed as payable dollars. But now that they have their claims history report, we're hoping that they can see where those denials occurred, take action on them, and we can reprocess them. But we've recouped 80% of what was originally paid out. So we are down to the 20% tail. And of that $80 million, it's hard to say how much will be recouped and reprocessed once the providers attempt to correct those claims. Most of them are for authorizations. The provider type is not payable under that code. I think that was detailed in Mr. Wynn's letter this morning.
Okay, thank you. Yeah, I was a little confused because I'm not sure I understand how we get from the 213 to the 80, and if that is the final number that really needs to be addressed, or,
No,
yeah.
and Chad can correct me, but we did see a decrease of about 15 to 20% utilization across the state in services because of COVID. And if you take $1.06 billion and take 20% of that, that's the tail we're working on. And then of that, the industry average on denials runs anywhere, and for behavioral health specifically, runs anywhere between, about 6 or 7% up to about 13%. We're running at about 16.5, so we have some work to do, but it's not so out of the ballpark. And I think some of that's that unprocessed claims that we have to address.
So is that 16% of the 214, or is that 16% of the overall 1
Yeah,
point,
hold
yeah? I need like a flow chart, if then, I'm trying to keep all of this.
It's complicated.
Make sure you introduce yourself.
Sure. Good afternoon, Madam Chair. Good to see you again. Chad Burkholder from Optum.
Good afternoon.
So what you're actually highlighting is right in line with what the remainder of the work really is. So as Ms. Riddleman mentioned, the $81 million and the details of what makes that up is included in some of the materials we sent to you that breaks down some of the key drivers, of those denials. The challenge of it is the balance, and that's really what you're asking about, is beyond the 81 million, what's the rest? And the rest is either, you could conceivably think that there are claims that a provider would still submit, but we don't believe that to be the case. The providers have been diligent about submission, and so we do not have any in current inventory that is delayed in any way, shape, or form in terms of processing of claims. And so that's certainly not an explanation. So the most appropriate explanation really is what Linda has highlighted, in that you have a difference between services that were provided compared to the dollar amount that was assumed based on the prior service year. So as we work through, we are expecting to continue to see that $81 million continue to be addressed in partnership with the providers. The providers would sit down with a reconciliation manager if needed, or would engage in other means of communication, would review, say, hey, this claim is one that I want to resubmit, or we think you, Optum, have made an error. We have already reprocessed everything we believe to be of Optum's error driver. So we don't have any inventory on that in that space now. So of that 81 million, I would suspect that a significant portion may continue as denied. Otherwise, frankly, I suspect it would have already been resubmitted. So, that would, hopefully that's helping to, make the connection between those couple of pieces of data.
Yeah, I'm trying to get a sense of timing in terms of the information getting to providers, because as you all, everyone on this panel knows, we continue, members of the General Assembly, continue to hear from providers that are either having issues getting things resolved. So talk to me about the timing that you're getting the information to the providers and the response in terms of resolution.
Sure. Would you like me to answer that?
Well, just
Go ahead.
quickly, we did get the claims history reports that I think a lot of the legislators were asking for, or rather Optum did, got them out to providers just in the last 2 weeks. So they're just beginning that look in a consolidated way at the detail. The first phase of that was to get something out the door last October called an 835. That's a industry generic, basically a receipt for your claim that shows you what you paid, or what was denied, what was withheld, what was overcharged, et cetera. But that was, I liken it to throwing a bunch of puzzle pieces on their desk and asking them to dig through it. We needed to put all those together in one report so they could look at a claim, look at all the transactions that happened to that claim, whether it was denied, reprocessed, paid out, withheld, et cetera, et cetera. Those reports just went out in the last 2 weeks. By law, we're required to give those providers 60 days to review those claims before we attempt to recoup any collection. So they're just getting started. And there's a lot of, for the large providers, that's a lot of data to go through. And that's why the reconciliation managers are on hand to help.
Okay, so they haven't necessarily really had time to determine whether or not there might be missing claims or
Correct.
your information squares with what they have on their records.
That's exactly right. We're just getting down to those detailed, fine details. I think a large chunk of them, providers haven't, for the most part, reconciled, but there's a chunk that now that they're working through, that they're, going back and forth with Optum to determine what the number is.
And there's a possibility that the inconsistencies between what they have perhaps in their records and what you have may even contribute to some of that pot that we
Oh,
were saying,
absolutely.
what's
Yeah.
left.
Yeah, it could.
Yeah.
We're pleased that the life cycle report went out 2 weeks ago. There were 683 as of Friday. There were 683 that were requested. All 683 were delivered in a timely manner. It is interesting and frankly compelling that of those 683 that have been delivered, to date, only 187 of them have actually been accessed or opened. And so we're working very actively with providers to encourage them to use that tool. Those who have used the tool have offered a lot of positive feedback and have expressed that it is actually precisely the type of information that Linda mentioned that is really needed. And then the other element that we're working on very diligently, in the 835 process, there has been about a 1 to 1.5% data irregularity that is being addressed. We think that will be addressed in near completion over the next 2 weeks. Data irregularities after that would be, we would be about a 99.97% strong, kind of data strength, if you will. And it's also important to note that even today, with those data irregularities, the providers are successful if they're engaged with a reconciliation manager to work through those data challenges. And that actually has been something that our team is able to resolve on their behalf. They were not able to without those corrections, but we have been able to do that. So the point is that engagement in the process matters. We're pleased to offer better tools. We absolutely agree that those tools were important and should have been provided. And now using them and engaging is going to be critical.
Thank you. And I'm hearing in your numbers, you talked about over 600, sounded like close to 700 in the potential pool of needing to help get things resolved. How do you get the information to the providers that this tool or this resource is available and that these reconciliation assistance, or I forgot what title you used, that these folks are available? What is your outreach program to the providing?
So several methods are used to communicate that. So one, MDH as well as Optum meets with the provider community numerous times a week in large group settings. In addition, written communications have been sent to the providers to notify them of the tools that are available. And then actually, we'll even do, unsolicited manual outreach, especially if there's a provider that we see as, having a larger need maybe than others. And so those three ways are ways that we're attempting to reach and engage.
Yeah, I guess I'm just a little troubled because you're defining a process that you have less than a third of the people who would need assistance getting it resolved. So I guess offline, I'd be more interested in hearing about, again, your meetings and your outreach. How many people are you connecting with? How many providers are you connecting with? Because it seems like there are providers who find us to try to help resolve challenges, and you're describing a situation where you have people on the ready to assist. So it feels like there's a little disconnect between what you're describing as being available and what the providers have perceived or experienced. Because they could save a step if the process you're describing is.
We absolutely agree, and we absolutely invite that discussion, and we would encourage you and your colleagues to encourage providers to certainly engage in the process directly. And but we'd be happy to speak with you in more
Yeah, and
detail.
certainly if there is a process or a speedy number that we can give folks to reach out to, or an email address, a point of contact, that we can in reach with the provider communities in our district, because there are some people that just aren't getting the information, or they're getting the information and are not getting the resolution that they need in order to get their claims responded to.
Thank you, ma'am. Absolutely. We'll take it as a follow-up and get those resources to you.
Okay, I'll pause. I've been talking a lot of there. I saw you, Senator Eckert.
Yes, thank you very much. And I am sure that you probably have reached out to the Eastern Shore Behavioral Health Group. Have you met with them?
The meetings are taking place with all the major provider groups and all providers. Linda, I don't know if you want to offer any particulars.
And not specifically, I mean, as Chad says, we do outreach to all providers. So unless there's a specific question that they have, are you referring to a specific problem that they're having or question?
Yes, it's ongoing. It's ongoing with the same situation I think that my colleague was presenting. Many times, the provider is being asked to provide information about a particular claim that has already been submitted multiple times. And that has been, I mean, I've been on the provider calls for the Eastern Shore. At least once a month, the Eastern Shore Behavioral Health Group meets and has been meeting with folks from Optum to be able to stay on top of this, to be able to communicate clearly what the issues in the field are. And many times, it has just been that the claims have been submitted, but then the provider is asked to resend the data or go back and review each of those claims again. And I'm just saying, I'm hoping that that has, at least we're beginning to resolve that.
Yes, I'll be happy to look into Eastern Shore specifically and get back to you if that, and follow up with that. But perhaps Chad can address the churning.
Yeah, and I want to jump in, and not to just jump in the middle of Senator Eckert's question, but to say that the members of this subcommittee hear these kind of concerns from our colleagues, not just on the Eastern Shore, but Baltimore City, Baltimore County. I've heard from either colleagues representing other jurisdictions or behavioral health providers themselves, to her point about just frustration and concern. So I wanted to join her comment on that.
Sure. So a couple quick comments. So one, it sounds like actually the process that you're describing is reconciliation in and of itself. It's an ongoing discussion of, you know, we don't think we agree with this outcome, this outcome, this outcome. Why didn't this pay? And then the resources within Optum, as well as even within MDH, would offer that feedback to the provider and encourage them either to correct a challenge that had been made, or if we identify that it's an issue related to a system defect or an Optum execution issue, the provider doesn't need to do anything in those situations. We would accept the responsibility to go address our own challenge. So, but it sounds like what you're describing really is the engagement process between a reconciliation manager and the provider. And then beyond that, I think that, you know, part of the submission process would be, you know, and just examples that I would think about here are, you know, examples like, a provider submitting an incorrect provider type, or a coverage not being in effect for a participant, or you know, a service not being a part of the contracted agreement with the provider. Those are the types of discussions, I suspect, Senator Eckert, that you may be hearing about, and those would be the types of things we would look to resolve.
Sir, I've been through the reconciliation process, either myself as a provider years ago with other ASOs. I know that. I am just saying to you, it is very frustrating to the provider when they call and there's a delay. They have to put additional people on to be able to track these claims one-on-one. They don't get a response, or when they get a response, it's something that has been sent multiple times, and it's not reconciled on your end. That's what I'm saying, that I hear mostly. I understand the whole reconciliation process, trust me. But it's very frustrating when providers continue. And these are providers who have been through this. They've been in the business for 25 and 30 years. They've been through 3 or 4 ASOs. They understand the reconciliation process, but there still have been issues, and that's all I'm just expressing. That I'm almost surprised because there has been somebody from Optum on those calls with the Eastern Shore Group probably every month since the pandemic and since the ASO started. So I'm kind of surprised that I'm not getting awareness of that. Thank
We
you.
will absolutely follow up on that.
Thank you.
Thank you, and on that note, I guess, I will say, I'll see if there are other questions from the subcommittee, but for the other colleagues from other jurisdictions that have expressed concerns and brought them to, certainly my attention, and I'm seeing nods from subcommittee members, are we to direct those folks to whom to help try to resolve their local provider issues? Because there are some.
Yeah, you can direct them either through, the normal MDH channels, or you can direct them to Monica McNeil, our CEO of Optum Maryland. We can provide, that email address, and we will, in every case, we will ensure that that's immediately entered into our issue management process, in which we would commit to, immediate engagement on those challenges and response.
And I will say that I have received some concerns that have been emailed to me directly. I've sent them through Mr. Yee and the
Yep.
Secretary's office and found them to be very responsive, but it shouldn't take people coming to me to get that resolution, I guess is the point.
We agree.
Okay, any additional questions from the subcommittee? Looks like you can take your seats. Thank you so much for your responses, and we look forward to your follow-up on those items that we've left outstanding. We do have, colleagues, some written testimony on our desks, and we have some witnesses signed up to testify. We'll start with Lori Doyle, and she will be followed by Dan Martin. So you can head this way. Good afternoon.
Good afternoon, Madam Chair. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland in support of the behavioral health budget, and would like to thank the governor for including the 3.25% rate increase. It will certainly help us with our workforce crisis, which we had prior to the pandemic, but has only gotten worse. The issue I do want to address my comments to is this whole notion of debt forgiveness. And so I thought the analyst did a great job in describing the chaos we've been under for the past 2+ years. So the question now, as we're getting to recoupment, is what indeed do we owe? I submitted a couple of slides to help visualize this. I think the discrepancy between what the department is saying and what the provider community is saying, they look like this in case you have your bill file in front of you. So the first one's titled Reconciliation and Accountability. So we all agree, all of us agree, that Optum paid some claims twice. We all agree we have to pay that back. No dispute there. The question is, these claims with dates of service from the estimated payment period, that January through August 2020 dates, there are still a significant amount of claims sitting in Optum's system that have not been processed. Some of them were denied in error. Some of them were retracted in error. Some of them were, providers have been told that they were paid, but they haven't been paid for those claims, so they're still sitting there. So to the extent that those aren't credited to the bottom line, it inflates the amount that we owe. And so that's what we're trying to get to. And I have to say, sitting here and listening to the dialogue you just had with the Optum representatives, I'm not here to say providers can't make mistakes. Certainly we can. And with this kind of chaotic rollout, there were plenty of opportunities to do so. But these providers have been doing this for a long time. We didn't just forget how to bill. We've seen an unprecedented amount of denials. Optum says, oh, the average is, 6%. In the old days, we were experiencing about 1% to 3%. Our denial rate was up to 16%. That's way out of line. So the next handout that I have is really a proposal that we've made to the department as to how we should deal with this issue. So what we're suggesting is that providers, again, pay all duplicate claims. We owe that money back, we agree. Optum, in turn, processes all these things that have been sitting in their system. And I have to say, we did a recent survey of our 95-member organizations, and they told us that of their recoupment amounts, anywhere from 2/3 to 3/4 is offset by these claims that are sitting there. It is significant. And so if you did that, if Optum paid those claims and we pay back the duplicates, what you're left with is what we submitted bills for, but the difference between that and the actual 2019 estimated payments. And so we think that probably the majority of whatever the difference would be is due to COVID. There were some downturns in services, and we know that. It was a very difficult period of time. But on average, what we're seeing from our providers is that they would owe, on average again, about $28,000. So we think that the forgiveness amount may be much less than what you've been hearing about. I looked at Mr. Garrison's analysis, and on the top of page 24, if I did my math right, he suggests that of the 2,600 or so providers, about 1,360 owe over $3,000. And that's without Optum processing these claims sitting in their system. We think that number will come way down. So I will close by saying that if you all do decide to increase the forgiveness, if we can come to this resolution and see what we really owe as a result from COVID downturn, and you decide to forgive some of it, we would urge that you do it across the board. All providers were hurt by COVID. All providers were hurt by Optum. And so it's not a matter of the size. Our margins are the same razor-thin margins, whether you do, a few services or a few thousand. And so we think if you decide, for instance, let's say $30,000 you're going to forgive. If you forgive all providers, then if you owe less than that, it retires your debt. If you owe more than that, you take $30,000 off that top. And we think that that's fair because it's really a matter of service mix rather than size. Residential providers got hit really hard. They couldn't do telehealth for their services. So again, I'll just close by saying I think this is a really good use of the surplus that we have for 2022. The numbers are not looking good in terms of the data on suicides and overdoses, and we'd be happy to work with the committee on a reasonable solution. Thank you.
Thank you. I'll hold questions until we hear from Mr. Martin.
Okay,
Good afternoon.
Good afternoon, Madam Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland. And as a Mental Health Association is a consumer education and advocacy organization. I want to get a little bit beyond the Optum issue and talk about kind of larger unmet need across the state and some things that we can do about it. Of course, we support forgiveness for our community provider partners who, in the midst of the worst behavioral health crisis that we've ever known, face the prospect of paying back these large unverified sums of money due to an IT dysfunction not of their own making. But like I said, I want to kind of get beyond that, just that general support, and talk a little bit about the unmet need that Mr. Garrison was talking about. We are really coming out of this pandemic, are facing huge unmet demand for services. Nearly 40% of Marylanders report symptoms of anxiety or depression last year, yet nearly a third of those individuals were unable to get needed counseling or therapy. Over 45% of Maryland youth aged 12 to 17 who reported symptoms of depression over the last year didn't receive any mental health care. Nearly 3,000, as you heard, nearly 3,000 Marylanders lost their lives to overdose. Another 650 lost their lives to suicide. 16 entire counties in our state have been federally designated as mental health professional shortage areas, and hospitals continue to treat hundreds of thousands of Marylanders for behavioral health crises. And so there are things that we can do to start addressing this increased demand. First, please support full funding for the Behavioral Health Administration. We're grateful for all the good work that the Behavioral Health Administration is doing right now. and a well-funded and fully functioning BHA is important now more than ever because of these reasons. We encourage you to support passage of the Behavioral Health System Modernization Act, which is Senate Bill 637, introduced by Senator Augustine in the Senate. I've talked to a couple of you about that before this, and while it's not jointly assigned, it does have significant budgetary implications. And so, again, I know you'll be consulted and as that thing moves forward, and I urge your support for it. Urge you to support supplemental funding for dedicated staffing at BHA to coordinate and implement a 5-year plan to address the cognitive and behavioral health needs of Maryland's growing older adult population. This is something that this committee raised up last year through adoption of budget language requiring some initial reporting in this area, and now it's really kind of time to make sure that we have the staff in place to move forward with that planning. And there are a couple other, speaking of language, there's a couple of other budget language or narratives, that we'd request of the subcommittee this year. One, directing a review of Maryland's process for screening individuals referred for placement in nursing facilities to ensure the appropriateness of those referrals. As Maryland's PASSAR program, pre-admission screening and resident review program, hasn't received the attention it deserves. The current process can take up to 2 weeks to complete, all while the individual's waiting in a hospital or institutional setting. And so we'd encourage language directing a review of that program and recommendations for improving it. And also language directing a review of Maryland's system of prevention and early intervention programming for youth with behavioral health needs, and whether there are other innovative programs that we should be emulating. Lastly, I'll just say you're going to be hearing from Mr. Rabbit from the Behavioral Health System Baltimore coming up soon, I think, about a request for initial funding for allocation of funding for Maryland's 988 program, just to make sure that we can really hit the ground running when that goes live in July. We would, Mental Health Association of Maryland supports that request too. And so, thank you for all you're doing. Again, thank the Behavioral Health Administration for everything they're doing, and thank you for your time.
Thank you both. First, let me see if there are questions from the subcommittee. Okay, I just have a couple of questions. You heard, and first, let me just say at the offset, having been in many meetings with the secretary and his team, Optum and their team, and you all, I'm convinced that everyone is really desiring to get resolution to this issue. So I guess my question is, and I kind of raised the issue to the secretary in that panel about the lost federal reimbursement on forgiveness. And so I guess my question, I know that everybody's working to try to get things reconciled and get claims that are owed paid and all of that. Can you help me they just shared that the providers that they've reached out to through their outreach process have not necessarily been opening or responding to their offer to get reconciliation help. Can either of you help me understand if people are receiving the outreach or what we can do to kind of help make that connect?
Thanks for the question, Madam Chair. And I think a couple things. We just recently got the claims history report that I think Ms. Riddleman spoke to. So it's fairly new. It's only a couple weeks old. I can tell you that our members are opening it and going through it with a fine-tooth comb. But what happens is usually if there's a problem, and we have a couple providers who are really up against it at this point, who could be facing significant, serious outcomes like layoffs and things of that nature. When they go to Optum, what is the usual response is, give us a few examples. We'll take it back, we'll look into that, and we'll see what's going on. And they may fix those few examples, but this goes on and on and on. So it is an awful lot of manual labor on the part of providers, first off, to go through these reports, try to figure out what went wrong. But then when we do have problems, there's not a global solution. It's we can fix these few that you have given us. And that, it takes an enormous amount of time. And I think providers, most of our organizations have, I call them billing departments, they're really one or two people. And so you're talking about a significant amount of time for these individuals to work through all of this. And I don't say that to cast aspersions. I appreciate all the meetings, and we have been meeting regularly. But it's just not working. We're exhausted. We need to get paid.
Okay, so I guess, and I definitely appreciate that and hear and have heard and read the frustration. It sounds like with the new information that is has now been made available in the past couple of weeks, that providers now may have the tools that they need in order to try to communicate in a broader sense versus those case-to-case examples you spoke of?
I think it certainly is the best tool that we've gotten so far, so I think it's a good start. But these claims that have been sitting there, I think this is going to be something that may have to go beyond that report, because I think what I just heard Optum saying is that those claims were denied for good reason, or they were retracted for good reason, and we're saying just the opposite. So there needs to be some meeting of the minds as to what really should be going on with these claims that are sitting there. It's a significant amount of money.
Yes, it is. Do you, the numbers that we have heard, that you heard today in terms of what is outstanding, what is the universe, is that consistent with what your?
I only know that when we have surveyed our providers, that of the recoupment amounts that they've been given, they say that between 2/3 and 3/4 of that amount would go away if these claims that are sitting there were processed and paid. I don't know in terms of the whole universe, we represent 95 organizations, but it certainly indicates that that amount would potentially come down significantly.
Very good. Well, we're going to keep tracking and working with all parties to try to get to a place where we can talk about some of the other important things in Mr. Garrison's analysis, because we do have some other matters and know the agency's working hard to address those simultaneously, and we want to be able to focus on the behavioral health needs that are still outstanding. Are there any other questions for this panel? Okay, thank you all very much.
Thank you.
Colleagues, we're going to hear from now Michelle Livshin and Chandra Chester. Please forgive me if I mess up your name pronunciation, and then we'll have Dan Rabbit on deck, so you're next. All right. Good afternoon.
Good afternoon. Thank you, Madam Chair and committee members, for your dedicated service, and thank you for the administration for all of your hard work. I'm Michelle Livshin with Honor Roan of Maryland. We're a behavioral health education and advocacy organization of peers, people with lived experience of mental health and substance use challenges. Our network of over 20 affiliated peer-run wellness and recovery centers, funded through the Behavioral Health Administration, offer free walk-in recovery support services to more than 5,000 Marylanders each year. For decades, our independent peer-run centers have been able to successfully reach community members with the greatest unmet needs, many of whom are unhoused, uninsured, and experience significant behavioral health challenges. At every center in our network, anyone can get one-on-one peer supporting groups, self-help tools, health education, and feel a sense of belonging that can literally mean the difference between life and death. In addition, our network has played an important role in de-escalating and diverting behavioral health crises from hospitalization. Centers in our network achieve incredible outcomes despite operating on medium budgets of less than $150,000 per year. Our peer-driven programs deliver services that meet the unique needs of the local communities, from our reentry program in Western Maryland to meal deliveries on the Lower Eastern Shore to housing support in Calvert County. We can be so innovative, flexible, and responsive because of the annualized funding we receive through the Behavioral Health Administration, and we dedicate every available dollar to direct services. Peer support specialists are an integral component of the continuum of behavioral health care. We must continue to protect robust investment through grants for peer-led programs like ours that are able to reach individuals and communities most in need, and which cannot manage the complexity and unpredictability of billing through the fee-for-service system. Now is the ideal time to invest in grant-funded peer-run programs, not only because of the essential support we provide, but because we are training the next generation of certified peer recovery specialists and community leaders. Our peer network is ready to support our communities through this behavioral health crisis, but we must have the adequate resources and funding to do so. We strongly urge the committee to vote in favor of full funding of BHA's FY23 budget. Thank you.
Good afternoon, Madam Chair and committee members. Thank you for this opportunity to be here today. I am Chandra Chester, Vice President and co-founder of Families First Counseling and Psychiatry. We are in Baltimore City, Howard County, PG County, and Montgomery County. We employ approximately 103 individuals and serve around 1,800 clients a year who mostly have Medicaid. Over the past 2 years, Families First has endured 2 crises. Since Optum took over as the ASO, it has been a nightmare for Families First Counseling and Psychiatry. We have experienced a higher rate of claim denials from Optum than we have with any other payer. In addition, the pandemic disrupted our services, causing our normal referral sources from schools and pediatricians to dry up. The impact of both of these disruptions significantly reduced our revenue. Because of Optum, Families First was also forced to hire additional staff, pay overtime, and overwork our staff, resulting in increased costs. Due to the increased costs and decreased revenue, we have had to restructure and cut positions. We have clients with significant mental health needs ranging from trauma to psychosis on a wait list due to having to downsize and not having enough therapists to serve them. Referring them out isn't an option in most cases because many clinics across Maryland are dealing with the same crises. This is a huge disservice to the population we serve during such a critical time when there has been a significant increase in children seen in the emergency room for suicide attempts. On top of it all, Optum is seeking to recoup $313,000 from Families First when we have $471,000 in submitted claims that have been lost or denied due to Optum. The volume of unpaid claims substantially inflate the actual amount Family First owes back to the state. Recoupment will further reduce Families First's ability to provide treatment to children and families in your districts. I ask you to support debt relief for behavioral health providers so we can focus our attention on meeting the needs of your constituents. Thank you very much for your time.
Thank you both for your testimony. Can you give me those numbers again? You said you have
Yes, ma'am.
313 in reimbursement, but what was the amount of unpaid?
$471,000.
Okay, thank you very much. And the question for you is, did you receive outreach? Are you working with the reconciliation?
Our CFO has been working with Optum since they came into play, since estimated payment started, since they started the recruitment process. We're on top of it. We've hired extra people to try to help us with that process, and we've gotten nowhere.
Okay, well, Optum has representatives in the room, so this looks like an opportunity that we can make a direct connect. You've got the secretary and his team that are very responsive and helpful, so let's see if we can at least get a conversation going and get somebody assigned to help.
Thank you.
All right, thank you. Any questions from the subcommittee? Thank you both very much for your testimony. And Mr. Rabbit, you can come on up. I think that's Dan Rabbit is the last person, other than folks from Optum, that I had signed up to testify. So if you guys want to jump up at the end, I have you signed up. All right, Mr. Rabbit, good afternoon.
Good afternoon, Madam Chair, members of the committee. For the record, Dan Rabbit, Policy Director at Behavioral Health System, Baltimore. We're the local behavioral health authority for Baltimore City. To start, we want to thank the Behavioral Health Administration for all of their hard work and express full support for fully funding their budget. We're especially appreciative of the rate increases that were provided for behavioral health providers in that budget. And that's especially important considering the acute behavioral health workforce shortage that we're seeing. I won't reiterate the statistics around the emergency that we're experiencing related to mental health and substance use needs in our community, but just to say that it really is alarming and really troubling. We see the launch of 988 as a key opportunity to try to respond to this increased mental health and substance use needs and try to slow and reverse this rising demand for services. 988, for those who are unfamiliar, will be the new National Suicide Prevention and Behavioral Health Crisis Hotline. It launches in July. And the big opportunity here is that it provides a new access point to receive services. It's 24/7, confidential support and connection to community resources. But the opportunity can only be seen through if we properly prepare for that launch. A SAMHSA-funded analysis estimated Maryland needs between $10 and $17 million to properly fund our network of local crisis call centers. In the analysis, it shows that the governor's budget did not include any additional funding for preparing for 988. There's $2 million that is expected from federal sources, but that leaves a pretty big gap in terms of being able to ensure that our local call centers have the staffing necessary to respond to this increased need. We made a request to the governor, again, that funds for 988 implementation be included in any supplemental budget that comes out, and we appreciate if anyone, any members of this committee can help to reiterate that request. We also want to second the need for ASO overpayment forgiveness, and just to, again, reiterate how difficult that's been for the providers that we support in Baltimore City. There's also another issue that you may or may not have heard of around invoices at the Maryland Department of Health not being paid. That's added like an additional stressor on our providers. And BHSB, we receive a lot of money from the Department of Health that gets passed along to our providers. We're behind $15 million in invoices and are running out of the cash flow necessary to float payments to support our providers in the city. So that also needs to be addressed expediently. Lastly, we just wanted to put on your radar some budget language that isn't in the BHA budget, it's in the DJS budget, but it directs BHA and DJS to collaborate on a report on how to reduce youth detention through the use of prevention programs that are youth-led and youth-designed. The report would review what we're currently doing in terms of prevention, look around the country at different youth-led, youth-designed programs, and offer recommendations. So those were the things we wanted to share in our remarks, and appreciate the opportunity to comment.
Thank you very much. Are there questions for this witness? Okay, thank you very much. And I did
you, Madam
find
Chair.
in the analyst testimony the part about the 988 hotline stuff, so thank you for that.
Very good, thank you so much.
Thank you. All right, we have Joseph Nguyen and Chad Burkholder from Optum. Good afternoon.
Good
And
afternoon.
good afternoon again.
Thank you again.
Yes. So, Madam Chair, members of the committee, good afternoon. My name is Joe Nguyen. I'm Vice President of External Affairs for United Health Group. You heard from Chad earlier. We're here just briefly to provide a performance update on the ASO. In the interest of time, I'll hand it over to Chad to walk through some of that, and we'll be here for questions.
And I'll be super quick. We've covered a lot of items already, but I did want to touch on a couple of items. So one, you know, as we've talked about before, right now Optum's focused on two primary elements. Number one, of course, supporting providers in the reconciliation process. We've already discussed that at length. And then number two is ensuring that the system continues to function effectively in current day, if you will, after the August 2020 date in which you know, things were moving forward. We're actually overall quite pleased with the overall operating performance of the environment since that time, although we absolutely continue to acknowledge the challenges that the estimated payment period had, not only on the providers, but on MDH as well as Optum. And we understand, you know, the criticality of addressing that. We frankly are fully aligned with the provider community there. There were a few things I just wanted to address really quick. One is the idea that there's volume of workload that's sitting, quote unquote, sitting and not being addressed. And frankly, that's not correct in any way. Right now, claims are processed at around 99.7% within 14 days, and providers are actually receiving payment 99% within 14 days. And so significant, the inventories are really flowing significantly and have been. The area that Ms. Doyle was referencing, I suspect, was really closely aligned with the estimated payment period, in which in cases where a provider, where we have a denied claim and a provider has a concern about it, Optum has taken steps over the last year, but certainly over the last 9 months to address system-related challenges. At this time, any inventories that we have that are system-related are literally being measured right now in like the $100,000 range. So we're looking at $150,000 to $250,000 of current inventory which is being managed. Very, very small. The remainder, we are being very overt in addressing with providers as areas that they would need to address. Similarly, then, the idea that there continues to be ongoing missing claims would not also be that would not be a correct assertion either. And in any situation where that's taking place, we're working directly with a provider to understand what would have caused a specific situation, and we address it. The other area that I would want to just cover is around denial rate, quote unquote, being out of control. And the Beacon denial rate operated around 15%, and right now we're operating at 16%, very much in line. Furthermore, the organizations that largely represented by CBH dramatically outperform that. They're at around 6.7% denial rate, a very, very strong rate. Now, they may have experienced something different previous, but their rate is differentiated. And I would also say that one element that continues to be overlooked, at the same time of ASO transition, very significant state policy changes were also enacted. They were enacted to ensure more accurate support of services and more accurate payment of claims. So those are other areas that I think we need to really address. And then, finally, I would just say that, we genuinely appreciate the engagement with the providers and, frankly, with the MDH leadership as well. And I appreciate the comments that the chair mentioned. There's tremendous hard work going on. We promise to stay fully committed to it. We are bringing more and more resources every month to bear, and we'll continue to do so to ensure that things are supported. And we are, frankly, very much looking forward to getting past this, hopefully in the coming months, and put it behind us and then perform, frankly, as all of you would expect and I would expect of our organization. So thank you for your time.
Thank you. Are there questions for this panel? Okay, seeing none, I thank you very much. I have some written witness testimony that I'm going to share with you after the hearing rather than hold up the conclusion of this meeting. Let me just thank each of you for taking your time to participate in this hearing this afternoon. As I said earlier, I think we all share the same priority, which is meeting the behavioral health needs of Marylanders. And so we're going to work together to ensure that we can do that. Thank you all so much for coming. Thank you to the analysts and our team. Have a great afternoon and a great week.